Okay, so metabolism, what we talk about huge is first pass effect. So this is number 2. We're looking at another effect of metabolism. One was sort of genetic enzymes, and now we're looking at first pass effect. So they're generally absorbed through the small bowel. I think this is in your notes. It's picked up by there's actually a picture I think you have, picked up by your mesenteric arteries. So you'll see if you absorb a pill, there's a huge blood flow that takes it right to the liver. Only oral drugs are affected by first pass. It's really affected. All drugs in some ways. IV drugs, probably not. They're directly fed into your body systematic. They skip a lot of this. But first pass is a big concern with oral drugs. Question, Ali with the mic.
You've never gone over this with us.
With what?
First pass effect?
No. And so I'm going to go over it and I'm going to talk a little bit more about
It's on
it.
the quiz.
Was it?
It was.
Yeah, it might have been, but it was in your notes from Unit 1. It was in your notes. And it was in your notes in Unit 1. It was there. If you read the oral section, it talked about it. So it was there. Question.
Just a slight question. In our books and our readings, it did have that the first pass effect also included sometimes rectal or suppositories.
Yeah. I know there's sometimes other meds are affected, but most significantly affected will be any med that you take orally. Most significantly. Okay. Pardon?
Will that include elixirs as well?
Yeah. Sublingual sprays that you put on your mouth, those sort of things, any sort of oral routes, okay? So what we talk about, especially ones are PO meds, because PO meds go into your stomach, then they get the most affected by first pass effect. Okay? So that's a picture you have. So the liver begins a reaction. So if it goes directly into the liver, you start to have a reaction right away. Okay? So there's less drug available to go to the site. So if most of your drug is directly going to the liver and being metabolized right there and probably then ultimately excreted much faster, less of it's going to get to the site where you need it. Okay? So we got to think about the body tries to metabolize drugs, but we do want drugs to go to target sites. That's the goal of drugs. We don't want the liver to metabolize all the drug. We need it to get to whatever target site. So if it's an opioid, we need it to go to a pain receptor, right? We need it to get there. But it's a consideration with PO medication that the liver may metabolize. If it's a drug that's metabolized by the liver, if you start looking, you'll look in your drug book, you'll see which drugs are metabolized exclusively by the liver. They'll talk about, and you'll start to notice, how come the IV dose is way smaller and the PO dose is way higher? And so, explains why PO doses are normally given higher than any doses any other route. So you might have to take 50 milligrams of gravel PO to have the same effect that 12.5 milligrams IV might have, okay? Because of the first pass effect. Particularly with morphine and other opioid pills, they often have to give a much higher dosage. You might have to take 10 or 20 milligrams of morphine PO, but it would be equivalent to 5 milligrams morphine IM. Why is that? First pass effect. The liver is taking up so much and metabolizing so much of that drug, it's out of your body before you can really use it the way it's intended to be used. Liver is just doing its job. It's just metabolizing things. Right? We weren't designed to take pills. We were designed to take in food, have it broken down by the liver, right, and transformed into things. So the clinical example, and this is where you get into, this is analgesic equivalency. And if you get into palliative care or you work in any sort of surgical area or emerge, you really start thinking about this when you're dealing with a patient. Let's say you got a patient you're giving IM doses to, you want to switch them to pills. You got to start thinking about analgesic equivalency. It's not the same between PO and another route. Okay? So you have to think that we think about this a lot when we switch someone over with palliative care to morphine PO. One of the things we're thinking about is we may have to increase those doses. We don't want to poke them with a needle anymore. Right, we may have to. And typically in palliative, we go to sub-Q. We avoid all of that. But we start to think about pain relief. And it really might be a consideration if you start thinking of a patient with liver failure. Right? Because medication dose that we give you, let's say I give you 30 milligrams because I know it's going to be absorbed by the liver. You got a trash liver, you don't metabolize those 30 milligrams. What happens to you?
You get a
big dose. Okay? And so we see this with liver failure patients are really complex in the hospital to care for. And they're very complex in pharmacology, and this is one of the reasons. Another reason, amongst all the other reasons why livers are important, is dosages aren't the same. PO particular. So they might become toxic, right? Present with a DIG, I won't use DIG because I'm not sure, I can't think of an example agent right now, but certain medications they might present with toxicity, and you go and look and you find out their liver's trashed, right? So, and the thing to think about is some medications have toxic effects on liver, and so it's sort of a cumulative effect. If your liver can't metabolize a drug, the drug has more effect on your liver. So some of those people are very susceptible to damage to the liver, excessive. In fact, a lot of liver damage is done by drugs. How would you suspect if someone had liver disease? How would you guys know? They're not likely to say to you, I've got liver disease. They might, but how would you suspect?
They would have a large abdomen, probably ascites.
Yeah. So that's more probably later stage, but yeah, you would have ascites. That's what you said, large.
They would have bilirubin in their skin.
More adverse reactions.
See that?
Do they
Maybe more adverse reactions that would make you think, why was that person affected so badly? Okay. You might want to look for, so you got ascites, jaundice, so that's bilirubin. Someone mentioned bilirubin. So if they're a little yellow, and always look in their sclera of the eyes. Always look in your eyes. The whites of your eyes is where you'll see it first in any patient. You always sort of feel like, are they yellow? And you'll grab another nurse, and two of you will look, and you'll say, yeah, they're more yellow today than they were yesterday. And then you go look in their eyes, and you'll really notice in your sclera, your whites of your eyes. That's where you'll see it. History of alcoholism. If someone's got a history of alcoholism, automatically suspect liver damage. Right?
So why do they get bruising? Like, don't they have increased bruising?
Yeah, it's got to do with blood clotting factors and other things. Yeah, liver failure is really kind of complex. Have you guys done that in patho yet? No. It's kind of neat to get into. Once you start looking at that, that's one as a student nurse, I thought, wow, once I understood that, it really explained a lot of the stuff I saw in the hospitals. They do talk in your notes. Some meds can never be given orally. There's some antibiotics that you cannot take an antibiotic pill. There are other meds that can never, ever be given orally. And that's because the first pass effect is so great, why even bother? Why even bother giving you the drug? It won't work that way, okay? Fentanyl PO, there's a great one. I've never seen fentanyl PO, ever. Now, there may be, but I don't think so. I think we use fentanyl patches, we use fentanyl IV, but I've never seen fentanyl PO. It is, in your notes, we talk about sublingual and topical preparations. Maybe that's why we use them so much, okay? Nitro pill, why are we still using nitro pills then? You'll see patients have the nitro spray, so that bypasses most of the first pass because it goes into the tongue and the blood flow. Or they have a nitro patch, but we still see lots of patients on nitro pills if they're older patients.
Really?
Pills. You'll still see people with nitro pills, but they aren't even sublingual. They're not even there's sublingual ones, but you'll see some patients that come with a pill. Maybe, or maybe it comes from an older style of education where nobody knew about this, like nobody thought about that. Yeah. Could have or no effect, right? Could have or no effect. So we've still seen, there's a nitroglycerin sustained release formulation. Well, why not put them on a nitro pass? And then you don't have to worry about that whole first pass effect, right? There's some meds that you want to really be careful with that.